Thank you, Rodeo. Jana Gardner-Gray. I'm one of the EMIM Critical Care 6 years, and today we're going to be discussing procalcitonin in the ICU in regards to sepsis. I'm pretty psyched about this lecture because at Henry Ford we have a lot of resources, but this is one of the things we don't have here. They're actually using in other ICUs and emergency departments, so it's going to be pretty interesting to see what we get from this. So. All right, so my outline for today's lecture is we're going to talk about the need for biomarker identification in disease states. We're going to talk about the importance of differentiating between SIRS and sepsis, which is kind of a hot topic as of late with the recent articles coming out. We'll talk about the physiologic role of procalcitonin, and then we're going to talk about procalcitonin specifically as a biomarker in sepsis. So we'll talk about it in a few different ways. A lot of times people kind of blanket using procalcitonin for sepsis, but it can be used in different ways in regards to sepsis. So we'll talk about it in terms of using it for antibiotic initiation. We'll talk about looking at procalcitonin in terms of the kinetics to stop antibiotics, and then we'll talk about procalcitonin to escalate antibiotic therapy. So we'll start out with a case. So you have a 76-year-old male in the ICU, comes in with the chief complaint of weakness. He has a hemoglobin of 4.2, but he gets scoped upper and lower, and he has no evidence of a GI bleed. During his initial resuscitation, they did place an IJ, and the patient got blood products and hemoglobin stabilized. He looks clinically improved. Everything looks like it's on the up and up and getting better. So the plan for the team is to transfer this patient to the GPU tomorrow. However, lo and behold, overnight, this patient slowly has some changes. His white blood cell count goes up to 12, but he's still afebrile. And this is around the third day of his hospital admission. You say, you know what, we're going to culture this guy. You get blood, you get urine cultures, and then your team is debating on whether you should start antibiotic treatment. So you look at his vital signs of physical exam for some more information. Temperature is 38.2, a little tachycardic at 110. Blood pressure is 90s over 60s, and he runs about 100 systolic, so maybe a little bit lower, not sure. And he's at tachypnic at 24, but doesn't look like he's in severe respiratory distress or even moderate. Let's see, hold on. This one, right? Yeah. You do the HENT exam, it's non-contributory. Skin looks okay. From a cardiovascular standpoint, he's tachycardic, but no new murmurs. Respiratory, we talked about it, he's a little bit tachypnic, but lungs are clear. And GI exam is again benign. So you'd look at the neuro exam, looking for some answers. He's alert and oriented, no focal deficits, but maybe a little bit more sleepy than yesterday, you're not sure. And the initial imaging is non-contributory. So kind of a limited case presentation. So based on the people in this room, how many of you would start antibiotics on this patient if you were rounding in the intensive care unit? Just by show of hands. I have one taker. How many of you would withhold antibiotic treatment? Okay, so about 4 or 5, and then a few undecided people in the audience. So again, another question. So this guy comes in, looks like he's getting better, and then he has some kind of non-specific findings that could be concerning. What would your differential be for this gentleman? Now you can just shout it out. Sepsis. Okay, Rodeo, strong answer. What else could this be, potentially? Transfusion reaction. PE. So I expected a lot of answers to be thrown out, just because it could be anything, right, at this point. So the differential right now is broad, right? Anything from a PE to a medication reaction to, like we said, transfusion reaction to, he has a central line, does he have sepsis? It could be any of these things. So we don't know. But what we base kind of our workup on, our evaluation on now in the ICU, is kind of the sepsis syndrome. So it was described by Bone in the 1980s, but it was well documented even before that. And he talks about a few different things that we're very familiar with. Fever, hypo and hyperthermia, leukocytosis and leukopenia, tachycardia and hypotension. And a lot of these things we're still using in our evaluation for sepsis today, our SIRS criteria. And even though we're not just using these, it's kind of evolved over the past half of a decade or so, well, not half of a decade, 25, 50 years or so, longer than that. The Surviving Sepsis campaign is still using this in our workup for sepsis. So the reason we have kind of this confused approach, or we have this conundrum in the ICU, is because we have two things that are causing a similar response and they're causing the same effect. So you have this damage that's done. Infection causes damage with a pathogen-activated mediated pathway. So what happens is you have this bacteria enter the body, and you have these exposed antigens. Your immune system kicks in, and you have this release of these components from the bacteria or from the viral cell that results in immune cell activation. A different type of damage can cause a similar response. So you can have sterile inflammation, and these are in the SIC, you see these in your post-op patients. You can see these in patients with autoimmune disorders, trauma, reperfusion injury, pancreatitis, and burns. And they activate this different pathway, which is the damage-activated mediator pathway. And with this, you also have release of components from your mitochondria and things like that. So the similar response is the immune cell activation, and you have the similar release of inflammatory mediators. So in both of these, you have the release of your interleukins, your tumor necrosis factors that we're familiar with. And the issue is that it leads to the same exact effect. So it's difficult to differentiate between which of these pathways is actually occurring. So from a central nervous system standpoint, you go see your patient in the ICU, they're anxious, they're delirious, or they could have a depressed mental status, some of them actually seizing. From a respiratory standpoint, these patients are tachypnic, they're in ARDS, or they're hypoxic. From a cardiovascular standpoint, you have these cardiomyopathies, or just nonspecific tachycardia. From a GI standpoint, they're not absorbing their food well, they have decreased motility. They actually can have bacterial translocation from this inflammation or infection that's occurring. From a urinary tract standpoint, you can have ATM, tubular necrosis, and from an endocrine standpoint, you can have a nonspecific fever or altered metabolism. So what happens as a result of this, being intensivist in the ICU, it all kind of comes down to us prescribing a lot of different antibiotics, so leading to heavy antibiotic use. So different things can contribute to this, which we'll go over. In terms of numerous infectious complications, there's three main things that this article discussed. This is specific to the ICU. We have a lot of breaches of the natural barriers, right? So just like the case, we have the guy with the central line that's in. A lot of these patients have ET tubes in, so we take away a lot of the natural defenses that you and I have. You have local or systemic immune dysfunction. So these patients are relatively immunosuppressed. So again, that leads to numerous infectious complications that we're aware of. And then, of course, you're dealing in the ICU with severely ill patients. Other things that contribute to the heavy antibiotic use are diagnostic uncertainty, just the nonspecific findings we talked about in the sepsis syndrome. Lack of knowledge. This person with pancreatitis is bad, they're febrile, they're hypotensive. Let me start antibiotics, even though you know it's not generally something that you would need to treat with antibiotics. I don't think unavailability of ID specialists is really an issue here at this institution. In addition to that, the pharmaceutical marketing pressure, I'm not really feeling pressured here at this institution either. But the guidelines is a big thing. We know from previous studies that have been done on sepsis that early antibiotics actually lead to decreased mortality. So we want to get those antibiotics in as soon as possible, and that's not a bad thing, it's a great thing. And then the patients we're dealing with have little functional reserve. So if you wait that extra hour for culture to come back, or even an x-ray at some points, you may miss something. That patient may deteriorate. So you start antibiotics again before those things come back. And one of the biggest things is you're afraid. You don't want to miss a life-threatening infection. So you start antibiotics empirically, and then you kind of circle back and do the workup. So what happens in this situation is that you end up in this kind of circle. So you give these broad-spectrum antibiotics, and then your patient develops more antibiotic resistance. And because antibiotic resistance are increasing, you give broader-spectrum antibiotics. So it's kind of going from your vancomycin, cefepime, up to your Zyvox, meropenem, and then, what's next. So we're caught kind of in this pattern, and for good reason that we talked about above. So antibiotics in the ICU. These comments or these facts were came out of the JAMA article in 2009, International Study of the Prevalence and Outcomes of Infection in ICUs. And what they basically said, they looked at multiple ICUs, and the EPIC surveillance showed that up to 71% of ICU patients were receiving antibiotics at one time. And the antibiotic resistance was directly correlated with this. And they stayed on average 6 days longer in the hospital, 6 to 12 days longer in the hospital when they had antibiotic resistant infections, which makes sense. And the length of stay in the ICU directly correlated with antibiotic resistance as well as increased hospital costs. So now we see that there's a big push from the medical community to say, hey, don't prescribe as many antibiotics. This is from the Healthcare Epidemiology Report, and it basically kind of pushes us to be better antibiotic stewards. So what they say, or what they define antibiotic stewardship is, it refers to a set of coordinated strategies to improve the use of antimicrobial medications. And the ultimate goal is threefold. So number one, they want you to enhance patient health outcomes. They want by reducing resistance to antibiotics, and they also want to reduce unnecessary costs. So this sounds great. I think this is something that we all should be doing. But again, we talked about how this is difficult in the ICU. They go about saying, there are two ways you can do this, and this is the kind of the advice that they gave us. They said use antibiotics only for true bacterial infections, and just shorten the duration of your treatment. So all of us have rounded in the ICU, and we know that's just not that simple. We can't just say, we're going to stop antibiotics on a patient. The patient's on day 5 of 8 of antibiotics. They're culture negative. It doesn't mean we can just stop it just because we don't have a true bacterial infection. We know the results can be detrimental, so we keep our patients on these medications. So as a side note, I'm at West Bloomfield this month, and I was making my presentation. So I put this picture up, and one of the employees walked behind me, and they were like, "Oh, you have such a beautiful family. They look nice." So this, just to clarify, this is not my family. These are people off the internet. So this is my son, and this is my husband. He's a dentist. So just so we can clear that before we move on. So the biggest thing, the Jackie did make that meme. So moving on. So the biggest issue we kind of face is sepsis versus SIRS, right? And it's kind of the battle of the ages. A problem is that we have no gold standard for the diagnosis of sepsis. We have our diagnostic criteria, but we depend a lot on microbiologic cultures to distinguish between the two. And specifically in the ICU, there can be a lack of sensitivity and specificity, even when the cultures come back positive. So these patients have been in the ICU for a while, and you send off the mini BAL, and you have 4 or 5 organisms that come back growing. What do? You keep them on the broad spectrum. You don't know which is the causative organism. And again, you kind of end up in that kind of rat race. Also, cultures often have a long turnaround time. So we start antibiotics empirically, you're waiting 2 days for your cultures to finalize. So even if you're able to differentiate, it's further down the line. And these patients are already started on antibiotics, appropriately so. So it brings us to biomarkers and individualizing patient care, which is kind of how the spectrum of, I think, treatment in general is shifting from malignancy to sepsis and everything in between. So the definition of biomarkers, it's an objectively measured characteristic, and it can be an indicator of both a normal or a pathologic biological process. In the literature I read, this acronym came up actually multiple times in defining what a good biomarker should contain. So it's the SMART acronym. S, specific and sensitive biomarker, should be measurable, it should be reportable and available, responsive, reproducible. You should be able to obtain it in a timely manner. So other things I saw when researching, which would be applicable to the ICU in terms of characteristics we may want in a biomarker, it should be independent of comorbidities, not modified by renal replacement therapy. It shouldn't be fatigable or exhaustible. You want it to give you some information besides what you're getting from your clinical evaluation. And you want it to shorten your time to diagnosis or to treatment. So specifically talking about biomarkers in sepsis, there are numerous biomarkers that have been tested for sepsis. The ones that I saw that have a lot of research being done on right now, and I'm sure Dr. Rivers can comment, there are probably a lot more, are procalcitonin. And I think the first study I saw was in '93. Was a procalcitonin article, but multiple have been done between them and now. C-reactive protein, your soluble urokinase, and the macrophage inhibitory factor. But again, for the purposes of this lecture, we're of course focusing in on procalcitonin. So speaking a little bit about procalcitonin, and I'm sure you all are probably familiar with this, but just to review, 116 amino acid protein, it's a precursor to the hormone calcitonin. These are found in the thyroid cells, has a role in calcium homeostasis. So if they were to check a procalcitonin level at any of us, it would be very low, pretty much negligible, less than 0.1, because it's not normally found in the body, which makes it a great biomarker. So in the patients that they used for most of these studies, patients that had a level less than 0.1 were again considered to be aside or apart from the group that was getting the antibiotics. Specifically speaking about procalcitonin and sepsis, what happens is that when you have a bacterial infection, It's hyperexpressed by the spleen, kidneys, the lung, and the liver. And this is in response to endotoxins and cytokines. The infection stimulates a rapid release of procalcitonin into the bloodstream. And the studies used different cutoff values, but the range was either between 0.25 to 0.5 for most of them. And those cutoffs had a sensitivity, you see the wide ranges, from 73 to 100% sensitivity, and for specificity, 48 to 99%. Now, those wide ranges depend on are dependent on a couple of things. The sensitivities and specificities were done in the emergency department, in the outpatient setting, as well as in the ICU. And then they were determined on the different types of infections. So they're better for some infections, or they've been more well researched in some infections than others, meaning, for example, like a meningitis versus bacteremia versus a lower respiratory tract infection.
So that was set with sensitivity associated with any
Yeah.
positive bacterial culture or viral or just
What do you mean bacterial culture?
like you had that was they were sensitive for a bacteremia or a pneumonia that had a bacterial culture. That didn't include viruses or else.
Oh, no, so it doesn't include viruses, which is the great thing about procalcitonin. So this is looking at the kinetic profiles of different biomarkers of a bacterial infection. So procalcitonin has a rapid increase between 3 and 6 hours only with the bacterial infection. It peaks at 24 hours. And the great thing about this is that it will stay at 24 hours until the infection starts to clear. So when your infection is resolved and when it's clearing, it should clear by about 50% each day, which is not seen in a lot of other biomarkers that I saw during my research for the presentation. Another great thing about procalcitonin is kind of what Gina was mentioning on, I think what you were asking, is that when you have a viral infection, it actually releases cytokines that suppress procalcitonin release. So you won't see that rise in your viral infections. Is that what you were getting at? All right. The other thing about procalcitonin and sepsis is that we all know sepsis is along a spectrum, right? So you have your SIRS, you have sepsis, severe sepsis, and septic shock. You actually can see procalcitonin values rise in relation to sepsis severity, which is another positive feature in terms of using this as a biomarker for these patients in the ICU. So kind of applying procalcitonin to that SMART acronym that we spoke about before in terms of whether this is a good biomarker or not. In terms of being specific and sensitive, in the pro-con debate in 2008, our critical care journal, it documented that it can have a negative predictive value of up to 99%. It's measurable. You send off your lab, it comes back fairly quickly. It's not a send out. You can send it and get it back within the normal time to get lab values back. And so it's a realistic clinical window that you're dealing with. It's affordable, which we'll talk about a little bit later. It's readily available. It's responsive and reproducible. So it reflects the active disease process. When you have a biomarker that's actively clearing as your infection's getting better, this is something that you can follow on a day-by-day basis. And then it's timely. Similar thing, it reflects the changes of the underlying condition that you're dealing with. So I wanted to make note of this. This was in the Infectious Disease Critical Care Journal. And it spoke about procalcitonin and renal disease. And the reason I wanted to touch on this is because we all know we see a significant amount of patients with chronic kidney disease and end-stage renal disease. So I think kind of understanding how this fits into that context is important, as well as we know that almost more than 50% of your patients that are admitted to ICU have some sort of acute renal injury that's happening. So 36% of CKD patients without an infection will have an elevated procalcitonin. And up to 100% of those patients on hemodialysis will have an elevated level of greater than 0.5, these are both even in the absence of infection. Also, procalcitonin, after you undergo either hemo, peritoneal, or a CVVH, will have a decrease in that procalcitonin level. So this study actually went as far as to make cutoffs for procalcitonin in the specific patient population. However, something to be aware of is they did comment at the end, and the kind of general opinion right now is that we can't use it in these patients because we don't really have enough data out there. But the cutoff they used was if you have stage 1 to 4, it shouldn't make too much of a difference. So they used the general cutoff of 0.25. And if it's stage 5, if you're on hemodialysis, peritoneal dialysis, or CVVH, they 0.25 and 1 to 4. And then if you're on the bottom list, if you're on dialysis, you're stage 5, they use the 0.5 cutoff in terms of treatment with antibiotics. So we'll go over the uses for procalcitonin. And again, instead of using it as a blanketed biomarker, we'll talk about it in terms of initiation, discontinuation, and escalation of antibiotics. So this is a study out of Lancet in 2004. Initially, when the studies came out, they were done in the emergency department in the outpatient setting. And then we transitioned into the studies being done in the ICU. So this was the effect of procalcitonin-guided treatment on antibiotic use and outcome in lower respiratory tract infections, and it was a single-blinded trial. So it's a prospective trial done at an academic tertiary hospital, and every patient that came into the emergency department, this was done specifically in the ER, came in with either a cough or shortness of breath, or both, and they were then divided either into a standard group or into a procalcitonin group. The primary endpoint was they wanted to see if people in the procalcitonin group utilized less antibiotics than the control group. So the algorithm that they used was they would order that procalcitonin. If it was less than 0.1, antibiotics were strongly discouraged. So that's the level that you and I live at. If that level was between 0.1 and 0.25, they still discouraged antibiotic treatment. If it was greater than 2.5, antibiotics were encouraged, and if it was greater than 0.5, they were strongly encouraged. And because there could be that lag between 3 to 6 hours, and some studies actually say 6 to 12, if antibiotics were not initiated on arrival, they would repeat a procalcitonin value within 6 to 24 hours. So after 13 days, they followed up on these patients. And these are after they had their diagnosis for the shortness of breath and cough they came in with. So you can see in all the groups, there was a trend towards less antibiotics being given, but it was significant in the acute exacerbation of COPD and in everyone that kind of fell into this other group that came in with respiratory distress. Even in the CAP, bronchitis, and asthma, though, even though it wasn't significant, there was a decrease in the amount of antibiotics given. The limitations of the studies, it was a single-blinded trial, so the physician was aware of the group assignments. And antibiotics were actually given in 9 patients when the procalcitonin was less than that value, that 0.1, that you were not, so it was strongly discouraged. And it was given in 13 patients when it was discouraged, that group less than 0.25. Regardless, this, along with a lot of other studies, came out, and it started actually, came out, and then they started actually doing like meta-analyses and systemic reviews based on that information. And we didn't go over all the meta-analyses because there have been a lot, but I took a quote from each of these trying to kind of sum up what the gist of their papers were saying, and I put the references below. So the first one commented that procalcitonin markers were particularly good for differentiating bacterial infections from viral infections. The second was saying that procalcitonin represents a good biological diagnostic marker for sepsis, severe sepsis, or septic shock. However, they put in the caveat that they don't think this could be extrapolated to ICU patients as of yet. Then they said, we found the diagnostic performance of procalcitonin for identifying bacteremia in the ED to be moderate. And to that point, most of the studies were done in lower respiratory tract infections. In children, they ventured out of that with meningitis and things like that. And then procalcitonin cannot reliably differentiate sepsis from other non-infectious causes of SIRS in the critically ill adult patient. As an emergency medicine community, a lot of people actually started implementing this. I mean, people use procalcitonin right now. Even at U of M, they do use procalcitonin in their ED, and they use it similarly to lactate when they're in their patients that come in with infection. But it hadn't been validated at this point in any ICU setting. They included ICU patients in some of the studies, but it was too small of a subset. There's a lot of heterogeneity. So the next step was to start doing this in ICUs. So the PRORATA trial, I'm sure some of you are familiar with. It's one of the big trials dealing with procalcitonin in the ICU. Was done in 7 French ICUs, and most of these studies are European. It was a randomized controlled trial with 600 patients. So the patients were admitted to the ICU. You see your patient. They're suspected with either bacterial, they're suspected with a bacterial infection. They're either not on antibiotics or they've been on antibiotics for less than 24 hours. And then they're divided into either the same procalcitonin group or into the control group. And what they looked at, in addition to the days of without antibiotics, they wanted to look at mortality at day 28 and day 60. So here's the algorithm that they used, and we'll touch back on this at the end. But you can see there's 2 different algorithms, one at the top and one at the bottom. The top is for the guidelines for starting antibiotics. So this is when someone comes in, you suspect infection, you order it times 1, that value. If it's less than 0.25, you don't give antibiotics. It's recommended you don't. If it's between that 0.25 and 0.5, antibiotics is discouraged. 0.5 to less than 1, antibiotics encouraged, and greater than 1, strongly encouraged. When you go down to that bottom algorithm, this is for stopping antibiotics. This is when you're getting a procalcitonin on a daily basis. So if your procalcitonin on any given day is less than 0.25, you would stop the antibiotics that you previously treated on that patient you suspected an infection. If you see a decrease by 80% from the peak concentration, or if the concentration is between 0.25 and 0.5, you would also stop the antibiotics. Again, kind of on the flip side of that, if it's less than 80% or greater than 0.5, you'd continue, and it's encouraged. And if it's increasing greater than 0.5, they would say this is getting worse. You may want to actually consider broadening your antibiotic coverage. So the results of this basically show that there were statistically significant more free antibiotic days alive in the procalcitonin group. And there was a trend toward lower mortality in the procalcitonin group up to that through days 1 through 28. But when you go days 29 through 60, there was a higher mortality in the procalcitonin group, which kind of got a lot of kickback from the intensivists in general. So in terms of secondary outcomes, no real difference. Relapse, superinfection, ventilator days, length of stay, emergence of antibiotic resistance showed no difference between the two groups. So this is the Kaplan-Meier going over the overall survival. And you can see, even though not significant, there is a trend towards a lower survival in the procalcitonin group at that 60 days. And how they determined it was they compared the mortality using non-inferiority, and they used a non-inferiority of 10%. And they based this on the fact that for infectious disease societies, they use 10% non-inferiority when determining which antibiotics, when they're doing studies on antibiotics, and that's where they got that from. But that's often criticized, again, by critical care medicine groups, that was too high of a percentage for non-inferiority. And then we can see with the antibiotic treatment, again, there was significantly less antibiotics given in the procalcitonin group. So limitations, there was poor algorithm compliance of 53%, which is high. Antibiotics were postponed in 15 patients. They were stopped prematurely in 85, and they were continued when they should have been stopped in 85 patients. Also, 52% of patients, screened patients, were excluded, and relapse and superinfection were based on microbiological results. So they were saying, if you're basing it just on microbiological results, we could have missed some actual relapse and superinfections. Also, the biggest thing that I saw comments were writing letters to the author and things like that were in terms of that mortality difference. Other studies looked specifically at a disease process. So this was done in ventilator-associated pneumonia. It was a randomized study. I think this one was out of Belgium in 2009. It was a multi-center randomized controlled trial where they looked at 100 patients with ventilator-associated pneumonia. And they either just put them into that control group or into the procalcitonin group. And they looked at which most people look at is the antibiotic-free days, and the days alive assessed at 28 days. And this was after you diagnosed the patient with ventilator-associated pneumonia. So the results showed significantly increased the number of antibiotic-free days in the procalcitonin group. And it was 28 versus around 10. Reduction of antibiotic use by 27% in these patients that were previously could have potentially been thought to have VAP. And then in terms of secondary endpoints, again, mechanical free days they looked at, ICU free days, length of hospital stay, and mortality, they were similar between the two groups. So again, we're kind of seeing this trend where we're decreasing the amount of antibiotic days, but mortality and other things like that don't seem to be affected, which is what we want. The limitations of this study mentioned was that the duration of antibiotic therapy in the control group may have been more than what the guidelines are recommending. So at this time, we were saying, we were all comfortable treating with the 8 days for ventilator-associated pneumonia per recommendation from ID, but the patients in the control group were actually getting 15 days versus 8 days. So we have those studies, and there were many others along with them that were in the direction supporting procalcitonin. But there are a few studies that kind of gave people pause in terms of implementation, which is a reason why I don't think it's as widespread as it could be. This is in Critical Care Journal in 2012, procalcitonin usefulness for the initiation of antibiotic treatment in ICU. And this was a randomized controlled trial which had 5 ICUs with 500 patients. And they looked at the similar thing, antibiotic consumption, and the difference between procalcitonin and the control group. And then they also looked at the assessment of quality of diagnosis of the ICU physician, and they did this by determining the concordance with an ID specialist that they had enrolled in the study, or had reviewed the cases after the fact. So they ordered the procalcitonin level on all the patients with suspected infection, and again, similar algorithm, strongly discouraged if less than 0.25, discouraged if less than 0.5, encouraged for level above 0.5, and strongly encouraged for a level above 1. And the results were interesting. Everything was similar. So it showed no difference in length of stay, no difference in antibiotic administration, no difference in mechanical ventilation days or need for RRT, and the ICU mortality were all similar, were similar for both groups. However, 43 episodes where procalcitonin should not have been treated was treated with antibiotics. That level was less than 0.25, and 16 episodes when the procalcitonin was greater than 1, so it required treatment, they were not treated. And that's the criticism that this article gets. Also, they looked at the agreement between the ICU clinician and the ID group, and it was about 50% for both the procalcitonin as well as for the control group. Limitations to the study is that there were a high number of surgery and trauma patients, and again, we know that post-operatively these patients generally have a higher, they can have a higher procalcitonin value. It was unblinded to physicians. They took the one procalcitonin value. They didn't use serial procalcitonin levels, and the antibiotics were not given according to the algorithm in the patients that we just spoke about. The PASS trial was another trial that gave people pause. It was a multi-center trial, and this had a large number of patients, and the PASS team is actually doing another trial, another research right now. They used the procalcitonin to determine the need for antibiotic escalation. So the primary aim for this was to determine whether procalcitonin will result in initiation of appropriate antibiotic therapy earlier than standard therapy, and then again that same effect at 28 days. The secondary aim is whether procalcitonin would shorten ICU length of stay and duration of organ failure. So they randomized to either procalcitonin group or to the standard care group, except they used a cutoff of 1, which none of the other studies used. Or they also looked at the decrease in the procalcitonin. If it wasn't going down by 10% per day, then they said, hey, follow this other algorithm, which was mandatory escalation of antibiotics, and they intensified the diagnostic procedure. So they had specific culture, specific imaging you would order if these criteria were met. And the results showed horrible results for the procalcitonin group. There was higher consumption and longer duration of antibiotics. There was a longer ICU length of stay in the procalcitonin group, longer mechanical ventilation in the procalcitonin group. Days of renal dysfunction were increased by 5% in the procalcitonin group, even though there was no mortality difference. There was also increased use of broad-spectrum antibiotics, combination therapy, cultures, and imaging in the procalcitonin group in the PASS trial. And here's the Kaplan-Meier basically showing the survival was the only thing that was the same. Everything else was basically worse in that procalcitonin group. So people speculated why the difference in this study and not the other studies. And they say mostly they think it's because the procalcitonin cutoff was so different. They even put their cutoff at 1 as opposed to earlier when we talked about that 0.25 or 0.5. So they said, you know what, they could have missed so many early infections. Also, 6% of the patients in the procalcitonin group didn't receive appropriate antibiotics according to protocol. But as we can see, that's been happening in most of the studies that we've looked at. So what happens with every study when you have people pro and against, they try to kind of gather all the data and see what they come up with in terms of conclusions we can implement into clinical practice. So there were a lot of systemic reviews and meta-analyses. This one was done. I'll talk about that was done. I think this one actually was in Belgium as well. But the primary outcomes they looked at was the measure of antibiotic exposure. The secondary outcomes were, again, the mortality, ICU length of stay, the days on mechanical ventilation, and then the relapse and persistent infection. They also wanted to look at cost effectiveness. They totally looked at 7 randomized controlled trials, one of which was a neonatal study. And when they tested the quality of the trials, they said 4 were poor quality and 3 were moderate quality. And they were dealing with medical and surgical ICU patients. So the results basically of the systemic analysis review, meta-analysis, showed that there was decreased antibiotic exposure in that procalcitonin group with similar mortality rates, so kind of the trend of the other studies that we looked at. However, the ICU and hospital length of stay were the same, and they had comparable rates of superinfection and relapse infection. There were so many limitations with the meta-analysis, and this was one I picked out, but there were limitations with a lot of them. The studies included were small, Not all the studies included data on all outcomes. There's a lot of heterogeneity in terms of medical ICU, surgical ICU, certain exclusion criteria, and analyzed infections. The algorithms were heterogeneous as far as the cutoffs for the procalcitonin, and most of the studies were funded or sponsored by a procalcitonin assay manufacturer. And they didn't have enough data to even comment on the cost effectiveness, so they drew no conclusions in that regard. So a lot of review papers have been done since then, kind of summing up what to take from these articles and these analyses. This was in Intensive Care Medicine 2015. And they had 4 conclusions they came to. They said procalcitonin measurements may be effective in determining when to discontinue antimicrobials, which we've seen pretty consistently. The procalcitonin measurement seems to be ineffective to withhold or to escalate antibiotics in critically ill patients with a high pretest probability for sepsis. So that's kind of that one procalcitonin value that you're getting, and then you're making decisions based on that. Antibiotic durations has been consistently shown to be shorter in procalcitonin groups. However, they did comment that the adherence rates in these studies vary between 47 and 84%. And that's because they always gave the intensivist the ability to override. If you felt uncomfortable, you could always give antibiotics, no matter which group your patient was in. So now, after that, people started coming up with algorithms that you could use and implement your ICUs. And some of these are being used in ICUs, right now. But it's not, of course, being used here or in our emergency department. But they said we should use procalcitonin kinetics as our preferred strategy when approaching these patients in the ICU. So what that means is that you're getting your daily procalcitonin levels, and you're making decisions based on a level on a daily basis, either the clearance by more than 80%, or when you see a level that's less than 0.5 to discontinue antibiotic treatment. So basically, it would be the bottom half of that algorithm we saw earlier in the Lancet trial. So if the concentration is less than 0.25, you'll stop. If you see the decrease, or between 0.25 and 0.5, you're encouraged to stop. And then on the flip side, if there's not the decrease, if you're greater than 0.5, you continue antibiotics in these patients. So in terms of the cost of procalcitonin, it costs about $25 to $30 per assay in the U.S., and it's about twice the amount of C-reactive protein. Not a lot of studies have been done in terms of cost effectiveness, specifically in the ICU, but the kind of general thought is that because you have less antibiotic resistance, the total savings will be given. You'll have total savings given the increase in antibiotic free days. So I think the take-home points in terms of procalcitonin, and we can kind of open up for discussion, is that in critically ill patients, antibiotic discontinuation is safe and effective on the basis of procalcitonin. However, the effectiveness and safety to initiate or escalate antibiotics is less well established in critically ill patients. I think the reason it hasn't been implemented universally is because I do think that further trials need to be done, which are in place to evaluate procalcitonin use in critically ill. And when you're using biomarkers of any sort, it's a piece of the puzzle, so it shouldn't be used to determine what you do with your patient. It should always be used in addition to your microbiological information as well as your clinical assessment. And upcoming trials, the SAPS has already had the preliminary paper out, but it should be coming out soon. And then there's multiple other studies regarding specific disease processes with procalcitonin in the critical care setting that should be coming out in the upcoming years. Questions, concerns, comments?
I have a comment. It seems like for what the presentation is, correct me if I understood it incorrectly, is that the fall of this calcitonin seems to be the best bet on that is shortening the antibiotic days, and maybe and then reset your thresholds to when to start antibiotics. Now my comment is, in one of those studies, it was 14 days versus 11 days.
Mm-hmm.
And I don't know what subtype of patients they monitored calcitonin on, but if it was a critically ill patient with pneumonia, I'm only treating that patient based on the current guideline for pneumonia.
Mm-hmm.
It's 8 to 10 days.
Mm-hmm.
So with an average of 11 days, it seems to me to be, if I'm just thinking of pneumonia, I just get an extra day if I monitor calcitonin.
Sure, and that's been a common criticism in terms of what does this mean? So we know it has less significant antibiotic days if it's 1 day or 3 days, but how does that translate into anything else? And we don't know at this point, because I don't know if it's just too early, but it's a common criticism, and I understand that. So, sorry.
The study that you mentioned, did they exclude renal patients? Or I know you mentioned that there's a problem.
So a lot of them exclude end-stage renal disease patients, but most of them included stage 1 through 4 patients, and that's based on limited information. But the study that came out in the infectious disease of critical care medicine basically said if you're stage 1 through 4, you should be using the same cutoff as other patients. Again, I think the research still kind of needs some work, but they included them. Oh, go ahead.
Patients that are much more homogeneous, specific, problematic diseases like pancreatitis, ulcers, high counts, cardiothoracic patients, post-op, stomach and fever, high counts. And we use procalcitonin in those very narrow selective patient populations. Is there a literature to show that?
There actually is. There's a lot of, I didn't go as much into the surgical literature, but there's literature specifically on the cardiothoracic patients post-operatively. And you're right, they do tend to have a higher procalcitonin. They use the cutoff, most of the studies use the cutoff 0.25. They use the cutoff of 0.5 in those patients, and they had great results. They decreased the antibiotic duration with no change in mortality. And they specifically mentioned cardiothoracic patients in a number of papers. The pancreatitis, I didn't see any specific article pull out those types of patients and do it in there. But I think those are the kind of patients that that would benefit from these type of testing.
But don't you think it's too heterogeneous? I mean,
Yeah.
it's
And that's why it hasn't been implemented, because it's all over the place. I mean, even the specificities, sensitivities, the patients you're looking at, there's a few that focus in, like on ventilator-associated pneumonia and things like that, but the rest, there's just not enough information focusing. And it seems like the studies that are coming out, a lot of them are using like fever in a central line, then patients in pneumonia. They're kind of harboring in on one specific disease process in order to get, I think, better results. Immunocompromised patients were